So today we're going to talk about the SNaP device and how this is innovative technology and how this is sort of changing how we think and utilize negative pressure. A little bit about myself. My background is infectious diseases, so in the United States, there's really not any formal training like you go through to become a wound care physician. It's usually kind of going sideways, or you get to a point in your career where you start seeing something that's not being managed right, and that's how I basically got into wound care. Is that I would always be called in on these patients who would have these terrible infections, complicated wounds. We would start antibiotics. They would have their limb amputated, and that was kind of it, and that was not satisfactory. And as I got more and more into wound care and learned and did more training, it was amazing what a difference that I felt I could make, and then it basically became my career. I'm based out of Salt Lake City. I work for the Intermountain Healthcare System. I'm the medical director over wound care and ostomy, and we actually just recently got a fellowship started with Duke University out there, and we're mainly the wound care training component of the hyperbaric fellowship. So we're very proud to be able to sort of put in a more formal training system in a recognized fellowship. Now let's move forward here, and some of the things that we're going to talk about today. We're going to go over some randomized clinical trials. We're going to review those, look at the outcomes of those. There's also some case studies that will demonstrate sort of the ease of use for this, as well as the impact on the quality of life. These studies had these exit surveys that were done, that asking patients how this impacted their treatment course and how they were able to still maintain certain activities which they couldn't do with other electric powered devices. Now the SNaP family, I don't know if you're familiar or you stopped by the booth, but this is the main component of the negative pressure devices. There's a 75 millimeter pressure device, a 100 millimeter, and a 125. And this, the SNaP basically stands for Smart Negative Pressure Therapy System. And the new item here is the 150. This is a 150 cc container. The others were smaller devices with that holds 160 cc's. So this has actually been a wonderful addition in the sense that there are patients who have higher amounts of drainage than 60 cc's over, say, 72 hours. And we've been able to start utilizing this more often where we were using electrical powered devices. Now a little bit of the background on the SNaP. At Stanford University in 2007, there was a program called the Biodesign Innovation Program. This is like a postgraduate program where every year they put a challenge out there. And this year was a challenge in 2007 was to develop a negative pressure device that could be utilized basically anywhere, was less expensive, and as a result from this, they developed the SNaP, which is a device that is spring-loaded, and it's not like a coiled spring. This uses memory metal. It's a military tech metal. Basically, it pulls out straight, but always wants to coil back, and when it's pulling on this plunger, it always pulls back on the same amount of pressure all the way across that gradient or that distance from when you charge it. And a year later, hospital started utilizing the device, and by 2009, the FDA had approved it for medical use. So, it's a quite interesting story because this was developed in 2007, and this picture here shows the early model of it, showing it being used in 2010. This is Haiti after the earthquake, and there was a lot of blunt trauma, a lot of open wounds, and this is used on both acute and chronic wounds. And in fact, we're taking this device to Tonga in a couple months. I'm going on a medical mission there where the amputation rate is through the roof. The prevalence of diabetes, active diabetes in the population there is around 25 to 27%. So we're going there for education but also going there to help teach new wound care techniques, which they need sorely. We see a lot of these Tongans, because of the Mormon Church or the LDS Church, they have a lot of family in Salt Lake City, and people who are threatened with amputation will actually, they'll fly their family members out to Salt Lake for treatment instead of staying there, because it's almost guaranteed amputation. Now, one of the studies we're going to go over here is a 2012 study. It's a study that compared the SNaP therapy system with the KCI wound vac. And what they did is they directly compared this, but they also, as we mentioned, looked at secondary endpoints of ease of use and impact on quality of life. This is about the only study that I know that negative pressure therapy was compared directly with the KCI system. Now, this is a prospective trial. It's multi-center, 17 investigational sites. This is important because the demographic on this goes all the way across the United States and definitely hits different areas where obesity and hypertension and diabetes is rampant, whereas there's others where maybe there's a higher Hispanic population, where in the Northeast you'll see that this is a more homogeneous, sort of European population, or at least descendants. There was 132 subjects on this. They were randomized 1-to-1, and it was a mixed study. They looked at both diabetic and venous. This is sort of looking at the distribution. You can actually, the leanest state in the U.S. is Colorado, and the area out here, probably the most obese area in the United States, is this area in here. Now, the inclusion criteria for this is a little busy slide, but basically it's kind of a standard for all the diabetic foot ulcer studies that have come out, like with skin substitutes. It's sort of the gold standard. 18 years old, has a wound present, diabetic or venous in nature, no bigger than 100 square centimeters, but it has to be bigger than 1 square centimeters without a diameter greater than 10 centimeters. Present for 30 days, and it also has to be in a location where they can actually get a seal with the dressing that is used on this, the hydrocolloid dressing. There's a lot of exclusion criteria. Basically, the etiology can't be because of, say, vasculitis or malignancy, pregnancy, untreated or active infection, untreated osteomyelitis, or basically out-of-control diabetes. One of the big things here is a run-in period. For 1 week, they look at these patients, and if they close more than 30%, they're excluded, because they wanted to look at wounds that weren't showing a propensity for healing. They want to be chronic wounds. The comorbidity, you saw the distribution, demographic-wise, but the comorbidities between the two groups, there is no statistical significance between these two. So you can see, although I kind of highlighted where, or at least bolded where it was leaning a little more for the SNaP where it was higher, it seemed like there were higher comorbidities, but statistically, this p-value is greater than 0.05, so there's no statistical difference. Now this is the sort of the flow chart on this. The patients were initially screened or identified. They came back a week later, and this is where they were put into this pre-study enrollment, where it was a 1-week period. They had, during this time, they had sharp debridement, they had offloading. If there were venous stasis, they had compression wraps put on. Once they were qualified, then they were randomized with basically closed envelopes. It wasn't completely blinded, so it's difficult to blind these patients when one has a larger unit, and say the negative pressure or negative, electrically powered device versus a mechanical powered device. And so they were randomized to either the SNaP or the VAC, and they were treated according to the FDA indications, what they were approved for. So the SNaP has been approved for twice weekly, where the VAC is 3 times a week. And then they looked at either closure, if it was completely healed, or an endpoint of 6 weeks with these study patients. Now, when you look at this chart here, this is a Kaplan-Meier survival curve, but you can see here the p-values here are not significant, and that's the point of this study. The study was looking at, on the left here, the proportion not healed over time, and then you were looking days to healing. And so there was no area really on this curve where there was a breakout where more people were healing at a faster rate, or there was a reduction in the size at a faster rate over the course of time. So this basically points to the fact that was established with this, that there was no statistical significance, or the efficacy of both these devices were equal. And so, and that's key, because the electrically powered devices have always been sort of held as a gold standard. So now we have the gold standard being equal, in the sense that mechanical, non-electric, non-battery device can do as a good a job as the electrically powered. Now here's some of the secondary points. This is interesting. They looked at application. How much time does it take to put the, say the KCI drape or the hydrocolloid dressing on these patients? And they statistically looked at the folks who were involved with this to make sure there wasn't any event in the process that was making one dressing being put on longer than the other. So, was it location was more difficult to dress, versus one versus the other, and that analysis showed there was no difference in that. But what they found is that the average for putting on the SNaP was only 10.2 minutes, where we had 18.22 minutes with the KCI back. Now this 8-minute difference can be big if you're in an outpatient wound clinic. So if you say you put on 8 dressings a day, for negative pressure, well, that's almost an hour of the day that you have saved time when you're utilizing the SNaP therapy. And an hour out of the day gets your, for us, gets our our nurses out the door on time. I mean, that's one of the hardest things we have, because we're always having walk-ins, or we run into someone who had, things have gotten worse and you have to spend more time on them. And so trying to get everyone home on time is difficult, and this helps. Or if you do have walk-ins, you have more time to see a few more patients, by saving that hour out of the day. Now this is sort of a graphing of a exit survey. So everyone who completed the study, either they were healed or they reached the 16-week without falling out of the study, took this survey. And so the survey was asking things that we have been experiencing for years, with the negative pressure devices. One is noise. Is the noise bothersome? And the response to that, the blue being folks who are using the SNaP therapy, I disagree with that. It was not bothersome. And one of the things I hear with the negative pressure device, so this is kind of more anecdotal, but supported by this survey, is our patients who go to church. And we have a lot of folks that go to church, and they have to be in church. It's with the LDS church, it's 3 hours out of their day, and if they have a device that's sitting there making a lot of noise, and people are in rooms talking, it's disruptive and it's embarrassing for them. So they choose not to do that, even though it's a big part of their being, who they identify themselves with. When we put on the SNaP, those complaints disappear. There is no noise. Also sleep. It doesn't keep them up at night. They don't have to put it under a pillow. They don't have to put it into a drawer. These are all descriptions I have heard from my patients with electrical powered devices. Now, cumbersome, interfere with mobility. Again, folks agreed with the KCI or the electrical powered versus disagreed with that. It did not interfere. And we have folks who could not go to work, who needed a negative pressure device, who had to use electrical power. Either they were mechanic with the device potentially falling into the engine, or they worked in a clean environment and they couldn't exactly put it into an area in their clothing because it was so large. With the SNaPs, we've been able to get people back to work faster, just due to the discreteness and the small size. I mean, it can fit right under your pant leg. So we can look at sort of a graph that or a chart that kind of puts us in a little better perspective. Again, you can see, did it interfere with daily activity? 85%, it did not interfere with daily activity. 85% agreed with that. We're only 54 with the KCI agreed. Let's see, are there any other, rarely noticed in social situations, 81% versus 35. They were more noticed with the electrical powered. So in summary of this study, we see that it's equivalent wound healing compared to electrically powered negative pressure. Ease of use, part of that is shorter application times. Also, ease of use is when teaching your patients how to recharge this. If it loses its charge, it gets this red bar at the top, and if you go by the booth, they can demonstrate that for you. But when I first started using these, I was concerned because I was so used to a device that had an alarm on it. And this device did not, but after several months of using this, I noticed that the compliance rate went up, and people were not coming in with macerated wounds because the battery went out, or they unplugged it, or they couldn't get in touch with someone on the phone. They easily could put in the key, charge it, fix the bandage if there was a leak. It's very simple, and the compliance rate went up, basically. And again, as the surveys have shown, the quality of life for these folks went up when they required therapy like this. Now this is just sort of a collage of, when we're talking about this device, these are the type of wounds we would use this on. Again, these aren't study patients because some of these are on the planner service. That was one of the exclusion criteria. But we use this everywhere. We've used it on the neck, chest, abdomen. The extremely large wounds are the ones that you basically need, a larger device that can pull heavy suction, has a larger chamber. So, a big fasciitis case, this is not where you're going to use the SNaP device. So the next study we're going to look at is a study comparing the SNaP with the electrically powered device for venous leg ulcers. So this was kind of a subset of the original. The original had both diabetic and venous stasis, where this is just venous stasis ulcers. Again, we're looking at the relative impact on closure. It's a multi-center trial. This was 13 sites across the U.S. This is a smaller trial, 132. This is 40 subjects that were randomized, 19 into the SNaP group and 21 into the VAC group. Now, one thing I didn't mention is for consistency of measuring, the tracings of these ulcers were done using the VisiTrack wound management system with Smith and Nephew, and that was also done in the prior study we talked about. And again, this was over 16 weeks or until there was closure. Now, when these patients were looked at these study points at 4 weeks, 8 weeks, and 16 weeks, there was basically significant better healing at these points. Now this is percent mean of closure, not so much healing, but how the reduction in the size of the wound. So here we had a 10% reduction versus a 35%. And you can see all these are, every point during the 16 weeks, that there's significantly more reduction in the SNaP group, therapy group. Now, if you break this out instead of just reduction size into complete healing, you can see at 30 days, twice as many folks were healed at 30 days using a mechanically powered device, the SNaP therapy, versus the VAC. And when you look at the odds ratio of 3.56, so what this means, if these patients, if patients did not use the SNaP device, they were 3.5 times more likely not to be healed at 30 days. So that kind of is another way of looking at the odds ratio. And actually, they took this out to 90 days. I don't have the slide on that, but if you look at 90 days, there's still, this odds ratio is about 2, just over 2. So there's still a significant proportion of folks healed in the SNaP group versus the electrical powered negative pressure device group. And so this is kind of a similar Kaplan-Meier analysis that we saw on the last study. But what you can see here around 30 days, this is where there was this, we didn't see this deviation with the sort of this heterogeneous group with diabetic foot ulcers and venous stasis ulcers. But here we see a pretty significant deviation, and that's where it becomes statistically significant, where you get greater than 50%, where you get greater healing going out this 30 to 90 days. And this here's a couple of just case studies just kind of showing in this what was done in this study. Here at 4 weeks we have a lower extremity venous stasis around the ankle, and at 7 weeks you can see we have almost complete closure here. And then another similar one, and this is kind of a note, these are hard. It's hard to heal. You know, when you get down around the malleolus, this is a region that does not have good blood flow or good venous return. It's kind of a no man's land. It's the density of the vascular bed is even in a healthy adult is less in this area. So these tend to be very difficult to heal, and getting a device that can stimulate granulation and perfude, angiogenesis and increase compliance is key to success. And this, this is an example of that. So, sort of the takeaways. This is kind of the end of the review of these two. Proven equivalence, between the electrical powered negative pressure devices and the SNaP therapy. It's really not meant to replace, the powered system. These large wounds, large wounds are going to need, maybe 200 millimeters of mercury with a large canister, and the SNaP is not meant for that. It's meant to augment, and in our clinic we have probably replaced 50% of the folks who have used negative pressure with the SNaP now, probably even more than that. It's a time saver in the clinics. It's very easy to use for the patients, and you can see that there's an improvement in quality of life. And with the venous leg ulcers, it's shown to be more effective than the electrically powered.